So good afternoon, everyone. We're going to get started now. Let me introduce the topic of our presentation as well as our speakers today. So our title is Precision in Practice, Mastering Biomarker-Driven Management of Metastatic Colorectal Cancer. I'll forward the slide. So our speakers today is starting with myself. I'm Dr. Jewel Samadder. I'm a gastroenterologist and cancer geneticist at the Mayo Clinic in Arizona, in Phoenix, Arizona. Up on video feed today from Arizona, we have Dr. Christina Wu, who is a GI medical oncologist. She's also the vice chair of the Division of Medical Oncology at Mayo Clinic in Arizona. Dr. Safia Salaria is from Cleveland Clinic Foundation, is a GI pathologist there. And we have Bree Robinson, who is a nurse navigator in our GI oncology program at Mayo Clinic in Arizona. So our learning objectives today are to identify the role and implications of validated biomarkers, for example, KRAS, BRAF, MSI, in planning for management and treatment decision-making in metastatic colorectal cancer. Describe the importance of collaboration between gastroenterologists, pathologists, oncologists, nurses, nurse navigators, and advanced care providers in providing the optimal management for screening, prevention, detection, diagnosis, and therapy of these patients. Comparing and contrasting strategies to optimize biomarker test ordering and utilization in various practice settings, including both academic and community-based gastroenterology sites. So we're going to start with why should gastroenterologists be involved in this, and how can they drive precision care in metastatic colorectal cancer? Well, I actually feel gastroenterologists are really uniquely positioned to revolutionize the understanding and the approach paradigm in metastatic colorectal cancer, because we're the ones who diagnose it, and we take that first biopsy that makes the diagnosis that leads to all of the downstream aspects, everything from imaging, molecular testing, pathological review, to oncologic therapies. So during colonoscopy, our goal is to initiate consistent biomarker testing processes in collaboration with a multidisciplinary team, including the hospital or health system that you're part of. Early intervention needs to be swift, leading to an accurate diagnosis. Molecular insights from these biomarkers can guide personalized treatment decision-making for the patient. And collaborating with pathologists, oncologists, radiologists, and others is something that we intuitively do already, where many of us are part of tumor boards and multidisciplinary panels, and this is just another aspect of that paradigm. And this will lead to coordinated, timely referrals and multidisciplinary treatment planning that hopefully leads to better survival for our patients. So why should gastroenterologists take a role in biomarker testing? Well, number one, it can facilitate early and accurate diagnosis by ensuring we get adequate samples from the colorectal malignancy that can allow for biomarker analysis. That's something you're going to be hearing about in just a little bit. The importance of the biopsies we take, where we take the biopsies from, and how it can lead to this downstream biomarker testing. This biomarker testing can lead to personalized treatment, which hopefully will improve patient outcomes. It produces a bridge between gastroenterology and oncology that avoids treatment delays due to a lack of biomarker results, a need for a second biopsy of a metastatic or even the primary site can be avoided, such that we have that ability to optimize treatment. And reflex testing, when applicable, can be created as well in the algorithm. Patient advocacy, not all healthcare settings have comprehensive genomic profiling. And as gastroenterologists, we can advocate for our patients to ensure they get biomarker testing that can lead to precision cancer treatment approaches for them. When you look at genomics and in a cancer patient, really it spans the entire lifetime of the patient. You can talk about inherited cancer predisposition as a form of genetic testing that applies to patients when they're healthy, when they're at risk of cancer, when they develop premalignant lesions, or even regional and disseminated disease. When you have more regional and disseminated or advanced cancers, we're talking about tumor profiling, where we look at a tumor sample and we can comprehensively profile it for hundreds of mutations to guide precision cancer treatment. And then approach new areas involving circulating tumor DNA, where we can use essentially a liquid biopsy to look at a variety of mutations to guide cancer care, or for early detection and interception of cancer, what people call multi-cancer detection. I'm going to briefly talk about hereditary cancer here. This is something gastroenterologists are intimately aware of and involved in. So inherited or hereditary factors account for anywhere between 15 to 20% of all colorectal cancers. Understanding this underlying inherited cancer risk is important for letting the patient know why they developed cancer, why there are so many members of their family with colon, pancreas, uterine, breast, or ovarian cancer. It can help lead to cancer prevention opportunities in the next generation, and it can help guide precision targeted treatment strategies, especially for those patients who have Lynch syndrome. You can see in this pie chart here, about 10 to 15% of colorectal cancers are due to inherited monogenic causes, the most common being Lynch syndrome, thereafter being FAP and other polyposis syndromes. Another 20% in dark blue there are called familial colon cancer, where there's a strong family history of colorectal cancer in a first or multiple second degree relatives, but no one clear genetic cause. And about 65% of colorectal cancer is sporadic, meaning there's no clear genetic cause, there's no clear familial cause either. It's important whenever we see a colorectal cancer patient that we take a family history, and this involves 3 generations. So you want to start with the proband who has cancer sitting in front of you. Place an arrow on them in your pedigree. The circles are for women, the squares represent males. If it's filled in with the color, that means they have an affected disease, for example, cancer. And you want to draw your pedigree at least 1 generation up, 1 generation down, and along the side to represent siblings and cousins as well. You want to record the cancers or other diseases, the ages of onset, ancestry or ethnicity, and medical record verification when possible as well. When we talk about genetic evaluation for colorectal neoplasia, we often need to step back and think about who should we test? Do we test a patient who's affected with polyposis or cancer? That's usually the most meaningful patient. Or if the person in front of us tells us there's a significant family history of colon, ovarian, breast, or pancreatic cancer, maybe that's the easiest person to start testing with. You want to talk about what type of germline genetic testing should you do? Should you do a small gene panel that just covers the colorectal cancer genes or the breast and ovarian cancer genes? Or do you do an expanded panel with 70 or even 100 plus germline genes that covers all of the cancer types available? When we look at a tumor in our patient, we want to think about ordering immunohistochemistry or microsatellite instability testing. If that's not universally or reflexively done in our hospital system, we may order tumor somatic or circulating tumor DNA, called a liquid biopsy, to understand the genomic profiling of that tumor that can help guide cancer treatment decision-making. And then germline testing we talked about. Risks and benefits are something that's important to explore with our patient, including cost, discrimination aspects in terms of life insurance, disability, and employment. The disclosure of results. Have a plan for when those results come back to you or the oncologist, who is going to disclose them to the patient so that they are aware of how that's going to impact their treatment, as well as their familial cancer risk and their long-term screening and surveillance. And then are there alternatives to genetic testing that they need to be aware of, including the option not to have genomic profiling done? When you get germline genetic testing done, those results come back in 1 of 3 responses. So obviously negative, that we looked at those 70, 80, 100 different germline or inherited genetic causes. We could not identify a genetic cause of cancer. Positive, meaning we found a germline or inherited pathogenic mutation that's leading to an increased risk of cancer in you or your relatives. And there's something in the middle there in light blue, which is called a variant of uncertain significance, a VUS. A VUS means there's a change or alteration in one of those cancer genes, but as far as we can tell, it's not disease causing. Germline mutations, as highlighted on the left, are where that variant is present in the gamete. So either in the egg or sperm, and then come together and fuse to become an embryo. And every cell in your body from that point forward has that same inherited genetic mutation. The best examples in GI are that of BRCA1 and 2, where we talk about that with pancreatic cancer, Lynch syndrome, obviously as a risk factor for endometrial and colorectal cancer, and APC, which is an inherited cause of familial colon polyposis. On the right side of that diagram, you can see how somatic mutations, these develop later on. So they're not inherited from your mom or your dad. They're not present in that embryonic level, but they develop sometime during your adolescence, teenage years, or even into your adulthood. And that's the basis of a cancer developing. And those somatic mutations are present only in the tumor, but they can help us guide and decide on a treatment paradigm that is unique for your cancer. So somatic mutations, the purpose of somatic biomarker testing identifies specific genetic mutations that can guide treatment decisions and predict patient outcomes. When we talk about testing here, this is next generation sequencing. We can identify multiple genes at the same time in the tumor. These are rare but actionable mutations, and it does require a significant amount of tumor tissue that does not that has active tumor sample in it that we can test for this. These are a list of different biomarkers and the different treatments that are associated with them. For example, microsatellite instability or deficient mismatch repair leads to the use of immunotherapies. You have HER2, KRAS, BRAF, V600E mutations, KRAS, and RET, and each of them have different treatments that they can be associated with. And this is why this molecular testing is so important. What are barriers to biomarker-guided therapy? Well, limited infrastructure. Many smaller hospitals outsource this type of genomic testing of tumors, causing delays, or use very limited small size panels that don't test for all of those molecular alterations we're talking about. There's been a lack of training about molecular genetics in our GI fellowships, as well as even at our national meetings. It's underrepresented. A lack of institutional or practice protocols. Insurance coverage is complicated, though more and more insurances are beginning to cover precision-guided oncologic therapy, which requires this biomarker testing. And then guideline awareness. ASCO, ESMO, NCCN, which are primarily oncology organizations, all recommend comprehensive profiling for metastatic or advanced colorectal cancer. However, the GI guidelines haven't been consistent or have been slower to adopt this molecular profiling. So our key takeaways from this part are germline genetic testing should be offered to all patients with colorectal cancer. Somatic testing should be considered for those with advanced colorectal cancer. Biomarker testing results can drive treatment decision-making, and gastroenterologists, most importantly, can facilitate discussions with the multidisciplinary team and the patient about the importance of molecular biomarker testing and how timely results can impact management decision-making. So I'm going to send off to Dr. Salaria now.
Thank you, Dr. Samadder. Well, as Dr. Samadder mentioned, I am a GI pathologist. So this point of the session is going to be hopefully outlining to you guys the importance of the GI pathologist or the pathologist, depending on what your practice is like, not only in assessing the specimen, but also in helping you get the maximum results from the testing that you need and the oncologists need to further patient treatment plans. So let's start out with the very basics, and that is the kind of samples that I as a pathologist received from the providers. The most common is the GI biopsy, which is usually a small fragmented piece of tissue. Again, it could be normal tissue, it could be normal mixed with cancer, or it could be just cancer. But the point here is that this is a very small amount of tissue, and it's not possible to assess margin status, for example. If we move on to a polypectomy, usually these are intact specimens, and if they're properly oriented, can provide a very good assessment of the margin clearance, again, if the specimen is oriented properly. And then lastly is the resection specimen. These are usually having to do with surgeries. And again, these are optimum for cancer staging that is needed, usually, again, done in the setting of a surgery. The NCCN guidelines currently recommend that we do microsatellite assessment or mismatch repair testing on all newly diagnosed colorectal cancer patients. Again, as Dr. Samadder mentioned, all of these analyses have certain implications for treatment. The NCCN guidelines also recommend that we move to MMR or MSI testing on patients that have metastatic colorectal cancer if it has not been done on the prior biopsy, or if that's not available. This also includes HER2 studies and then KRAS and NRAS and BRAF mutations. And then there's additional testing that can be done that includes RET and NGS panels that are also part of the recommendations that again affect treatment options. Well, when is testing performed? The very easy answer to this is when we actually have invasive cancer. Now, if you go back to the type of specimens that I described, that could be in a fragmented biopsy that has a whole bunch of cancer, or that could be in a polypectomy, as you're seeing here, with the arrow highlighting a focal area of tumor that is invading into the submucosa, so PT1 and beyond. We need invasive cancer to perform these tests. What are the sample requirements? Of course, we need invasive cancer, as I mentioned before, but it's important to note here that not only do you need cancer tissue, neoplastic tissue, but for many of the molecular tests such as PCR and for NGS testing, you also need normal tissue. So when you're sampling these tissues, it's important to know that not only do you need to have a neoplastic sampling, but you also need to have concomitant normal tissue. I've put numbers here that are an average for based on different testing regimens for the amount of tumor that is needed, especially for molecular testing. Some might be a little higher, some might be a little lower, but 20% tumor content. So this involves how much of your actual tissue that you've sampled is viable tumor, or greater than 25 millimeters squared of tumor DNA needed. I want to emphasize here on not only these numbers, but also the viability, that you actually need tissue that is viable tumor. And I talk about that as we look at the next slide, because oftentimes you will see depressed areas, ulcerated areas, or eroded areas when you're at the scope looking through these to these lesions. It's important to note here that aggressive sampling, if it procures a whole bunch of sample that is not viable, is absolutely low yield to negative for further testing. And that's highlighted here by this sample up top, which you can see is a robust sampling, but there's absolutely no viable nuclei that you can see. In pathology terms, it's all pink. You're not seeing any blue nuclei. So that's all necrotic tissue. Whereby if you look at the bottom photomicrograph, you'll notice that not only is there some sampling of the necrotic tissue, but there is adjacent viable tissue. So what's important to drive home here is to sample around the depressed or the ulcerated or the eroded area, and not so robustly within or the actual ulcer. Now, when it comes to the three main testing modalities that we as pathologists send your tissue out to, currently the main three are immunohistochemical stains for mismatch repair, microsatellite instability through polymerase chain reaction, PCR, and then next generation sequencing. And this chart here highlights a lot of the salient features of all of them. What I'll point out here is that you can see that MMR IHC testing as a pathologist working in a lab does not require any extra equipment, any extra expertise. It doesn't require special training for the pathologist that is reviewing these slides. And I'll go into the details of what these slides look like. Whereas the other two, usually, as Dr. Samadder pointed out, are send-out tests. Unless you have a big referral lab, this tissue will be sent out. Having said that, as you can see, one of the limitations is that you need a certain amount of tissue. For immunohistochemistry, we can cut very thin sections. These are at the level of microns. And so if you go back to that polypectomy specimen, even if you have 4 or 5 glands that are neoplastic, if those glands can survive 4 levels of cutting, we do, and I'll talk about the 4 stains that we do, we can get you the answer to which proteins are being affected. The other thing, of course, is the turnaround time. Because immunohistochemistry doesn't require any extra equipment. It's done in-house. The turnaround time is usually 24 hours to 48 hours, whereas the send-out tests can be much longer, up to 2 weeks. This testing algorithm here is that some iteration of this is being followed by all of the labs, which you guys are connected with. There's some slight nuances as to whether MSI or MMR is done as a first-hand reflexive test, and I'll talk about what that is. But for the most part, for example, at my institution, we start out with immunohistochemical mismatch repair testing, and then depending on what the testing shows, we go down this algorithm. Again, it can be nuanced if there is PMS2 or MLH1 loss, if you go on to do MLH1 promoter methylation testing or BRAF. These are, again, slight nuances, but for the most part, these are the algorithm and testing pipeline that is followed. So how do I decide? How do pathologists in general decide if it's MMR or if it's MSI that we're going to do? Again, these protocols are usually set up by talking to the gastroenterologist, the oncologist, and the lab professionals themselves. And I will say here that the overall tumor amount or the tissue amount dictates which path I'm going to follow, whether it's a biopsy, whether it's a resection, and then the degree of invasive tumor. As I've mentioned, some tests are amenable to providing you the answer that you need based on just 4 or 5 glands, and some tests require a lot more. 5 pieces of invasive tumor is generally described as being amenable. And then, of course, you have to keep in mind the laboratory resources and protocols. I will point out here again that most labs prefer to go with MMR, immunohistochemistry, for the reasons mentioned before. It's cost effective, it's readily available. The person analyzing it doesn't need any special treatment, any special fellowship training or anything of that nature. And these results can, again, guide further testing. I will say here that whether your lab is doing MSI or MMR, there's a high degree of concordance between both of these tests. So it's nothing to be alarmed if one is chosen over the other. The protocol at the Cleveland Clinic where I work is that we reflexively do MMR immunohistochemistry on all newly diagnosed biopsies of colorectal cancer patients. We also perform them on resection specimens for colorectal cancer, if not done on the prior biopsy, or if the prior biopsy was done outside and we don't have that material. And similarly, if a patient comes with metastases and we don't have the prior material, then we will go for MMR IHC. Other than that, all other testing is clinician guided or clinician order entry. So that includes outside samples that are coming in for review at the Cleveland Clinic. That includes HER2 testing, PD-L1, and also MMR IHC. As you all know, this is done beyond just colorectal. So for any other cancer, that requires an order entry from you guys, letting us know that you would like this done. That is the protocol at my institution. I'm a pathologist, so you are not going to get through this session without some sort of interpretive pathology recognition slides. And this, again, I promise it'll be very brief and easy, but this is what MMR IHC testing looks like. So again, it's a reflexive test at most centers or most labs in the country. We do it on formalin fixed tissue, again, very thin microns that are cut from this tissue. Turnaround time is very quick. We analyze for 4 main genes, which is MLH1, MSH2, MSH6, and PMS2. And these, the expression here that is considered normal is the retention. And so that means that you would see brown staining within the nuclei of the glands. And so if you can see in the top photomicrograph here, the longitudinal glands are the actual adenocarcinoma, and you can see that they show brown staining. But I want to draw your attention to the background here, which are the stromal cells right here in the background. And we have to have this, and this is very important because these are the internal controls. So your lymphocytes and your fibroblasts that make up the background, they are always the internal control. They will have retained staining. Contrast that to abnormal staining, which is called a loss of MMR staining, which you can see again in the long linear tubular glands. The tumors have lost that staining, but again, the internal control in the background retains the staining. So the other good thing about IHC, MMR, immunohistochemistry is that you have a built-in internal control. Again, one thing to note is that this detects loss or absence. So it's a protein. It doesn't test for function, but it does guide you into which proteins to look into. Now, there's a lot of, like any other testing, there can be issues that arise. For the purpose of this audience, we're going to talk about the pre-analytical changes. And first of all and foremost is, of course, that you would not have enough tumor cells. So again, I've would like to highlight here that just because you have a lot of tissue sample doesn't mean that you're going to have a lot of tumor. And these two up here are nice examples. You can see in one point here that we have a biopsy sample. So very small sample, but that blue bracket highlights how much tumor there is, way more than 20% of the sample. Totally fine for NGS or for molecular testing. And then moving on, you have a huge resection specimen, and the blue bracket highlights how little tumor there is in this patient. So sampling robustly doesn't always mean that you will get the tumor. Next is the cold ischemic time. We want this tissue to hit formalin as soon as you get it out of the patient. If that's not possible in certain cases, to vacuum pack the tissue and send it to the lab at 4 degrees Celsius is ideal. Again, it's not a replacement for formalin, but it is the next best thing. And then of course, we use 10% neutral buffered formalin. And so if the formalin concentration is up or down from that concentration, it can also hinder the results of your immunohistochemical staining. So I hope I've highlighted here how a pathologist works as part of a multidisciplinary team, not only in assessing the diagnoses, but also in helping you get the most bang for your buck for the tissue that you're submitting. How we also help guide the protocols for your specific lab, and then you should collaborate and communicate with your pathologist for any testing that you need done based on the sample that you're submitting. So the key takeaways are, of course, to remember to submit normal and viable tumor tissue, and to be aware of the testing guidelines that your lab has. What test is done first, what test is done reflexively, and then also to communicate with your pathologist to optimize patient care. Thank you, and I will now move to Dr. Wu. I will advance your slides for you.
Thanks for giving me the opportunity to share how an oncologist approaches our metastatic colorectal cancer patients. Next slide, please. So want to stress the importance of precision medicine and how it guides our management right now. So this diagram shows the different biomarkers, and the size of the circles illustrates the frequency of which we find these biomarkers. So as you can see, probably about 40 to 45% of our patients, their tumors will not harbor a biomarker. But as you can see with these additional circles, there are a lot of other mutations that we're now picking up. So for the longest time, it was only KRAS and NRAS wild type patients that we could offer targeted therapy with anti-EGFR antibodies. But as you can see now, MSI high or deficient mismatch repair biomarker enables us to offer people a chemo-free option with immunotherapy. And most recently, now with HER2 amplification, BRAF V600E mutation, as well as KRAS G12C, we have good targeted options that we can offer in addition to chemotherapy. And that very small circle on the very top showing fusions are NTRK and RET fusions, but while they're very rare in frequency, are also very valuable for our patients when we're thinking about targeted therapy. Next slide, please. I think this graph really is trying to illustrate what we're trying to achieve when we're talking about targeted therapies. If you look at the y-axis, median progression-free survival, as described in months, shows how we are able to prolong survival for our patients. And the x-axis shows objective response rate, meaning what kind of reduction in tumor burden can we expect with these treatment options. In the light blue bubbles, you see nivolumab, pembrolizumab, and on the far right, nivolumab and ipilimumab. So this illustrates how offering patients with deficient mismatch repair or MSI high tumors and giving them immunotherapy, we're able to not only decrease tumor burden dramatically, but also prolong survival. And as you look at the other color-coded, one is the dark green, which is HER2 targeted therapy. We can also offer increased response rates as well as progression-free survival. And in the orange bubbles, you see for BRAF V600E mutation. And in this patient population, they do have worse prognosis, a much more aggressive tumor. But now that we're able to add these targeted therapies, we are improving our patient survival and quality of life. Next slide, please. Next slide, please. Keep going until I think this was meant to be animated, so please keep going. Stop here. So this is illustrating how I, as a medical oncologist, think about our patients as they walk through the door on their first consultation. So it's important to note that right-sided tumors versus left-sided tumors are considered a biomarker. They make an impact on how we decide how to offer targeted therapy. If patients have RAS or RAF wild type tumors, we actually look to see if they have left-sided or right-sided primary tumors. And if they are left-sided, we are able to offer chemotherapy plus an anti-EGFR antibody. But if right-sided, we know that that will not be efficacious. So something as simple as understanding left versus right-sided primaries is important for us. And then if they do have deficient mismatch repair or MSI high, or the very rare POL-E, POL-D mutation, we're able to offer immunotherapy. And that would be my first choice in order to spare our patients chemotherapy toxicities and hopefully get that response and survival that I illustrated in the prior graph. If they have BRAF mutation, this is newly FDA approved this year, we're able to offer chemotherapy doublets such as FOLFOX plus encorafenib, which is a BRAF inhibitor, and an anti-EGFR antibody. And we know that this can improve responses for our patients. What treatments our patients get in the first line determine what we offer in the second line. For instance, if we didn't have the NGS back yet and we were started with chemotherapy, in the second line, we would then want to offer the targeted treatment options as listed above. Important to know when we are after first line setting and second line lines, we can start adding on other targeted therapies such as HER2 targeted therapies with trastuzumab, which is a HER2 antibody, and tucatinib, which is a tyrosine kinase inhibitor. Or we can offer an antibody drug conjugate called trastuzumab deruxtecan. And most recently with KRAS G12C. As you know, KRAS in general is a very common mutation, but we have not been able to target it. But now we know that with KRAS G12 mutation, we are able to offer a KRAS inhibitor plus an anti-EGFR antibody. And for further lines of therapy, such as RET fusion mutations or NTRK fusions, we are able to offer targeted therapy in those settings as well. Next slide, please. So the bottom line is, how can the gastroenterologist prepare patients for oncology? Colonoscopy is essential to confirm the biopsy, and really identifying the site of the primary tumor is impactful as well. Core biopsies, if you find that patients have metastatic cancer, whether it be in the liver or lung, if you're able to work our patients up in those settings, if we are not able to retrieve tumor by colonoscopy or patients are high risk for some reasons, actually ordering a core biopsy and letting our interventional radiology colleagues know that this is for NGS testing is extremely important. And that also ensures that we have adequate tissue for our pathologists to also look at so that we can confirm diagnosis and eventually send out for NGS testing. You will see that we in medical oncology are also utilizing liquid NGS testing. There are nuances to it. In the end, tissue NGS is our gold standard, but with liquid NGS testing, the turnaround time is faster, usually with most vendors, 7 to 10 day turnaround time. And that can get these results in our hands as patients come to see us, because often we're still locating the tumor and sending it out for comprehensive NGS can take some time. From a GI standpoint, if you could order staging scans, that would actually really help expediting biomarker workup. And this is, and for colon cancer, it would be a CT chest, abdomen, pelvis in general. And for rectal cancer, a CT chest, abdomen, and an MRI pelvis. And if it's the anal cancer patients, it would be a PENMR. And the reason why staging scans actually help is that when we confirm patients have metastatic cancer, we are then enabled to order these NGS testing because as Dr. Samadder alluded to in the beginning, often insurances will depend on the staging of the cancer for us to be able to order these tests in a timely fashion. The CEA is a known serum tumor marker for metastatic colorectal cancer, so that could be helpful to know a baseline value. And then if patients haven't had MMR test, tumor status testing, to then ask your pathologist to get that tested. And then naturally getting a good family history and then considering referral to genetics in parallel with all of this is important as well. Next slide, please. So key takeaways, MMR testing absolutely essential because we want to be able to offer our patients immunotherapy if we can, and then obviously to refer them for genetic testing if we think that they may have Lynch syndrome. For metastatic patients, NGS testing is absolutely essential. We are now like our lung cancer colleagues where we really want all this testing in front of us as we start planning treatment options and are able to counsel our patients on what is the best regimen to start with. And finally, a thorough family history and referral to genetics. Next slide, please. And on to Bree, our great nurse navigator.
Hi. So yeah, I'm Bree. I'm one of the GI oncology nurse navigators. And so I wanted just to talk a little bit about what nurse navigation looks like for oncology patients. So first off, I always like to start with what the definition of a oncology nurse navigator is. And so a oncology nurse navigator is a professional nurse with oncology specific clinical knowledge who offers individualized assistance to patients, families, and caregivers to help overcome healthcare system barriers. Using the nursing process, an oncology nurse navigator provides education and resources to facilitate informed decision-making and timely access to quality health and psychosocial care throughout all phases of the cancer continuum. So takeaway from this is that oncology nurse navigators are more than just schedulers. We do more than just review records. We spend a large portion of our time educating these patients, making appropriate referrals to social work, to patient navigators. We also participate and organize multidisciplinary tumor boards or participate in multidisciplinary clinics as well. And so the coordination of care, obviously it's a lot that we do. We help coordinate appointments for these patients. And so some of the things that we look at when we go to coordinate these appointments for patients. First and foremost, we look at the pathology report. We need a confirmation of cancer in order to schedule those patients with an oncologist. And with that confirmation of cancer, we look to see, has MMR status been reported? Has that been run? And we generally do request those outside slides for review at our center as well. We look at those staging scans. So as Dr. Wu said, we look to see if any CT scans have been completed. If not, we take that upon ourselves to order. So we may order CT scans, MRIs, PET CTs, or even PET MRIs based on the patient's diagnosis. We also like to make sure that there's a colonoscopy report or even an EUS report. And it may seem insignificant, but having those pieces are really important for the multidisciplinary team and even for us as navigators, because it allows us to know more about where that mass or that cancer is at, if they're partially obstructing, if they are close to obstruction, and it allows us to be able to facilitate the next steps as well. Of course, we like having baseline labs. So very simple CBC, CMP, CEAs. If they're not ordered or not completed, that's something that we make sure that we set up for those patients before they meet with the oncology team. And then, of course, we do request any other pertinent medical records that are important for us to know, previous cancer histories, previous treatments, any other outside records that would be helpful for the oncology team. So as we go through the coordination of care and we help to organize those staging pieces, that helps us determine the next steps for those patients. Are they metastatic or are they not metastatic? And so with non-metastatic patients, specifically rectal cancer patients, we help to organize and coordinate appointments with our multidisciplinary team, which would include medical oncology, radiation oncology, and colorectal surgery. We like to make sure that we try to get those appointments either all on the same day or within 1 to 2 days of another so that the patient has a treatment plan when they're done with those appointments. With colon cancer patients, it's a little bit different. If they are non-metastatic, we typically work to get them an appointment with our colorectal surgery team where they can discuss surgery. And at that point, if surgery is completed and they actually do need oncology follow-up, such as, they have lymph node involvement, they have high-risk features, then we work to get them scheduled back with our medical oncologists. And then, of course, that leads us to patients that are metastatic to begin with. So in that record review, or as we go to work them up and we find that they have metastatic disease, we schedule strictly with medical oncology. And then as a oncology nurse navigator, we will actually order liquid NGS testing to be drawn and ran, hopefully to be completed before they meet with the medical oncologist. So as I said before, a lot of our time is not just ordering of appointments or scheduling appointments. We spend a large portion of our time advocating and educating for these patients. So big portions of our patient education are focused around our young patients. So specifically, where I'm at, we have an adolescent and young adult program, also known as AYA. So this program is for patients 39 years of age and younger. It is comprised of a specific AYA nurse navigator, social worker, and cancer patient navigator. And so they have very specific resources that they are able to share with those patients. They have support groups, they have psychosocial care, additional education on long-term side effect management from their treatments as well. They do educate also on genetic testing, the importance of genetic testing and why it's needed given their age. But a large portion of their education is focused around fertility preservation and referrals for fertility preservation. With these young patients, it's extremely important that they have that option before they do start treatment. And so they are counseled on the risk of infertility, the common preservation techniques, the potential costs associated with that preservation, and the amount of time that it does take so that they can make that decision. They also are educated on the financial costs, and then as well looped into, again, more support groups if needed. So again, next to AYA, we have patients that are not under the age of 39, but they are still young. We have our early onset GI cancer program for patients that are 55 years of age and younger. And a lot of our education as navigators with these patients is focused on genetic testing related to their cancer diagnosis. We educate on the importance of this genetic testing, and we educate the difference of genetic testing versus, liquid NGS testing or biomarker testing. So we take our time to really discuss and educate the patients on the reasons why we are doing this genetic testing so that they understand the potential cause of their cancer. It helps us to learn more, and it helps the patients to understand that as well. We also educate that when we do this genetic testing, it allows us as their oncology team to understand potential treatment options. If this does result in something that's actionable, we have other treatment options. It helps identify any other risks for cancer that they may be at. And again, we educate them that it's important to understand if they are at risk for any other cancers down the line. And then additionally, and finally, we identify if they have family members or even children that might be at risk for cancer down the line as well. So how can GI providers help prepare these patients for oncology? So I think, as we've all said, ensuring pathology has that confirmation of cancer, it really helps our providers, it helps the patients, and it helps get them the treatment. Obviously, we need a confirmation before we can discuss any treatment options. We ask that the providers advocate for MMR testing. So again, this may allow for additional treatment options for these patients. This may allow for other resources available to them, such as genetic counseling or genetic testing as well. Ordering staging scans and labs. I know it may be out of a GI provider's wheelhouse to order labs or even staging scans, but even ordering those things allows them to be scheduled in a timely manner so that one, the provider has adequate information to make treatment recommendations. But additionally, as we said, having that staging scan completed may alter their treatment recommendations in general. Again, if they're metastatic versus non-metastatic. And then ordering genetic or even NGS testing when appropriate. So as we said, a lot of the times we reserve NGS testing for metastatic patients. And again, I know that may be uncommon to order, but just to even think about. But I think most importantly here is genetic testing. If a patient has a family history of cancer, I think it's really important that the GI providers advocate for genetic testing upfront for these patients. And so it leads us to our key takeaways as well. So pathology diagnosis is important for patients to have a consultation with oncology. MMR testing can give oncology providers information required for treatment decisions. Initiating germline genetic testing for patients is important. And ordering staging imaging helps to decrease the time to treatment as well.
Thank you, everyone. That's wonderful and information for our gastroenterology community. I have a couple panel discussion items that I want to throw out and see if we can have some discussion around them. So the first one, I'm going to give this to Bree, but anyone else can jump in as well. So Bree, when patients call you or you're trying to schedule them with a new diagnosis of metastatic or advanced colorectal cancer, tell us, what do patients want to know about biomarker testing, about targeted therapies, about NGS? What is the words they use? Because this is really available in the lay media now. People are going to Google this and think about this. So what is it they ask you?
Absolutely. It's a really great question. We get that quite a bit. So first and foremost, we typically do get patients asking about targeted treatments. And so I think it's really important as navigators that we, again, educate them and discuss the reason or even the difference of biomarker testing and genetic testing. So we take that time to explain the difference of both, again, genetic testing versus biomarker testing, the potential turnaround time that it takes to get those and why they are important. So, we take the time to explain that having these completed, as you said, may allow for targeted treatments, may allow for immunotherapy. However, we have to make sure that we still practice within our scope and allow to have that further conversation with the oncologists. With that, a lot of patients ask about cost. It's a big question. These patients' lives have been turned upside down, and the first thing that comes to their mind is cost. What is this going to cost? And so generally, we briefly keep it that those younger patients, when we talk about genetic testing, we do let them know that generally that is something that is covered. And then with metastatic patients, when we talk about ordering biomarker testing, as long as there's the documentation to support that, that is generally covered as well. However, we defer a lot of the further conversation to our oncology team or even our financial counselors as well. And so, again, we advocate on biomarker testing even before appointments so that we have that before their appointment so that those treatment discussions can be had.
And I know because you brought up costs, even if we give just ballpark numbers, germline genetic testing's gotten a lot cheaper now. And generally speaking, there are several large germline testing labs that'll offer genetic testing for $250, even if insurance does not cover the cost of genetic testing. And more, regardless of the age of colorectal cancer diagnosis, and for patients with pancreatic cancer, universally, germline genetic testing is recommended and covered. Let me ask a question regarding to Dr. Wu there on the video. What information do you as an oncologist wish that an endoscopist would include in their report for you to look at when a colon cancer or rectal cancer is diagnosed? What are types of information that would be useful in their endoscopy report?
Yeah, so I think I hope I stressed the location of the primary tumor is very important for us as a biomarker. So I think that immediately has direct impact on first-line therapy. So where it's accurately at is very important. And for rectal cancer, even where it is with regards to the anal verge, the distance, that will likely make an impact on future treatment as well, even in a metastatic setting. The final thing, which Bree alluded to, is are our patients going to have trouble soon? Are we partially obstructed? Are we near obstruction? Because sometimes we may actually refer our patients to the colorectal surgeons first for a diverting colostomy if we're in a situation where we're worried about bowel obstruction.
Perfect. For Dr. Salaria, a question. What are mistakes that you've seen gastroenterologists make when submitting samples to pathologists in terms of biopsy errors or lack of specimens or samples? What are pitfalls?
Thanks, Dr. Samadder. I wouldn't classify them as mistakes, but I think some of the errors or some of the mishaps that happen in general practice for a pathologist are first and foremost not getting adequate sample. Now, whether that's tumor amount or even getting the tumor itself or viable tissue, as I highlighted. Another thing that I'll point out that isn't necessarily part of the sample acquisition, but is the provider is unaware of the actual testing algorithm and what is done reflexively. And so it causes a delay of sometimes a few weeks where we'll get a phone call and say, well, was this done? Was this test done? And so it's important to be aware and again, communicate with your pathology department in the lab to find out what is done reflexively and what the onus of what is on you for ordering from the get-go. It just expedites everything because we are there to move that tissue along. But if it's not part of the algorithm or if it's not part of the testing protocol, there's kind of like an unawareness.
Excellent. I guess the last one I'm going to talk about, and I want you guys to chime in, is really the care of patients with advanced or metastatic colorectal cancer is really multidisciplinary. It involves gastroenterologists, as we're the ones often making that diagnosis, having that conversation with the patient when they're waking up from sedation, doing that effective handoff to our multidisciplinary team, including a nurse navigator, if your institution has that, a GI medical oncologist, a GI pathologist. And maybe that's what I'm going to stress most. Know in your own institution and in your practice, who are those other players? Who is your contact in radiology, pathology, and medical oncology? How do you get your patient referred for next generation sequencing testing, ensuring IHC is performed in the tumor sample, trying to advocate for your patient to get into oncology in a timely manner, and really being their advocate. They're looking at you when they wake up from sedation and they've heard that life-altering diagnosis. You're their quarterback into this new area of cancer care that they've entered into. So with that, I'm going to go to our, if you're able to scan the QR code here, you can participate in the live polling. Are you aware of the importance of somatic genetic testing to drive targeted treatments for metastatic colorectal cancer? It looks like the answer is, after this conversation today, it's 100%. So that's good. Are you aware if reflex testing is performed in colorectal adenocarcinoma samples at your institution? So this is either microsatellite instability testing or more commonly immunohistochemical testing for deficient mismatch repair expression. And it looks like this has widely gained in acceptance both at larger academic hospitals, but also community hospitals and private labs that see colorectal cancer samples. I will kind of advocate what Dr. Salaria said, that though this is commonplace in colorectal cancer, it's not commonplace in all other cancers. So if you see a small bowel cancer, if you're seeing a pancreatic cancer, and there's young age or some other features in the family history, or endometrial cancer is a common example, you may want to advocate for mismatch repair testing by, again, emailing or talking to your pathologist. Are you having discussions with pathology related to reflex testing for somatic biomarkers? So I think this is 50-50, just as we would expect, right? You know, in certain academic cancer centers or large matrix medical centers, gastroenterologists are heavily involved in tumor boards and these discussions. But in smaller hospitals or in the community, this probably is the paradigm of the medical oncologist and something that really is a handoff. And medical oncologists are taking charge of somatic tissue and liquid biopsy testing, as well as the favorite type of panels that they use for genomic profiling. What barriers can you identify to having reflex testing widely adopted into your current clinical practice? Wonderful. So again, as we highlighted, cost and insurance, especially after a patient's just received that life-altering diagnosis, and obviously for a younger person, it can impact their employment and livelihood. There are always these implications of what is insurance going to cover, what is the cost out of pocket going to be. I think here, gastroenterologists play a very important role. Many of us are involved in our societies, whether that's ASGE, AGA, AASLD, ACG, NCCN. We need to really advocate for the importance of gastroenterologists in molecular biomarker testing and the importance of it for insurance to cover in order to pick the correct precision therapy. Insurance coverage really is dependent on NCCN and many other guidelines and white papers that our societies write, so we can be instrumental in getting that message out. If not, did this session make you interested in participating in multidisciplinary tumor boards? So if you are not currently doing it, are you interested in participating in tumor boards now that you've been to our presentation? So no, so maybe we scared off the audience. I think that's it. Thank you very much, everyone. And thank you for the honest answers too.